Hi, welcome to those of you who are signed on now, or it looks like we're gathering our participants for this next Primary Care Development Corporation webinar on the new normal, how primary care can reboot and reopen in the context of the COVID-19 pandemic. So we're going to get started in just a minute as we see our participants coming online. Thank you all for taking the time out this afternoon or this morning, depending on where you are, to join us to talk a little bit about primary care. As we're going to be talking about, primary care has not necessarily been the main focus of the conversation so far around COVID. So this is part of our attempt to put primary care front and center as we think about the kinds of things that our communities need in this moment. We need primary care, we need public health, and we need equity. So that's a different way of thinking about PPE, personal protective equipment, as well as primary care, public health, and equity. So we're going to be talking a lot about those things in the course of the next hour. So it looks like we've got a lot of people continuing to join us, so we'll wait for just another minute before we get started. Lauren, can you move to the next slide? So we just want to make sure that everybody knows that this is the second in a series of conversations about primary care in the context of COVID-19, what we're calling relief, response, and resiliency. Although we think those things are not necessarily happening in sequential order, we think that all those things are really quite critical for primary care. The previous webinar that we had with Dave Choksi and Farzad Mostashari is available as a recording on our website. Feel free to go pick that up. I think it was a pretty interesting conversation. Today we'll introduce our panelists in just a minute, and then on Thursday, May 28th, we're going to be having the final webinar in this series, talking about really raising the question, is this a moment for us to be thinking about fundamental change in how primary care is delivered and is financed in order to really be responsive to the needs in the community. Next slide. So PCDC, as some of you may know, is a national not-for-profit organization. We're a community development financial institution, which what that means is we're essentially we lend money to community health providers in order to improve access, quality, and health equity. We also provide technical assistance, strategic advisory services, and we work in an advocacy way because we think that more and better primary care is one of the key avenues for achieving health equity. Next. So today I want to introduce our speakers. I'm Louise Cohen. I'm the CEO of the Primary Care Development Corporation. And today we have with us Louise McCarthy, who is the president and CEO of the Community Clinic Association of Los Angeles County, CCALAC. She has worked in policy for many years. She was the past board chair of the LA Care Health Plan, and has played a really critical role in the pandemic relief and response so far. Jennifer DeVoe, Dr. DeVoe, joins us today from the Oregon Health Science University, where she is a professor and department chair in the Department of Family Medicine. She's also a practicing family physician and a health services researcher. And we were really glad to have both of them join us here today. Okay, I think that's our slide set for the day. So, so thank you both again for joining us. We really appreciate it. So just a few technical issues for everyone. We will in fact be recording this. We will be posting this on our website. And so we're glad that all of our participants have joined us. So let's just jump in. Michael Bennett, who is a primary care provider in Boston, wrote in the Washington Post in early April. He said, "A second hidden pandemic will follow COVID-19. We need to plan for it." And what he was talking about was the impact of deferred care on our communities. And so I guess I'd like to know if each of you can just tell us, does that square with what you're seeing in Los Angeles, Oregon? Do you think that COVID is masking what will come up as a serious second pandemic of deferred care? So Louise, why don't we start with you? What are you seeing in Los Angeles? What's going on there?
Sure, and absolutely, because we know that people are not going in to get care. And so just a little level setting, the Clinic Association of LA County, for folks that aren't from the left coast, we're about the size of New York State. 88 cities. Our members serve 1.7 million patients a year, and that's about half the people that live below the federal poverty level in Los Angeles County. So our members, since this has happened, reported that they have had a reduction in medical visits by 52%, a reduction in dental visits by 92%, and reduced behavioral health visits by 50%. So some of that's being taken up by telehealth, but it is not completely refilling the services that were being provided. And I want to say that we were not meeting the need before this started. So we were already dealing with a gap that we were trying to close, and then this just kicked us back further back from what our goal is. So we are absolutely going to be seeing deferred care, but then the issues of isolation that have exacerbated people's conditions, especially in the behavioral health and physical, you name it. Stay at home isn't necessarily good for people's health, depending on how they do it, and especially not if they're starting out from a place of a condition of needing care. So absolutely, we're going to see this second wave, and it's going to be brutal. It's absolutely going to be brutal.
So Dr. DeVoe, why don't you let us know what's going on in Oregon and what you see as the potential issues coming up with deferred care, or are you seeing that in Oregon?
Yeah, we are. I think all of us know that the need for primary care doesn't ever go away. It's not elective care, as we see with some of the elective surgeries and things that have been stopped in the state of Oregon and across the country. So our patients have needed us now more than ever. We're working harder than ever. Yet the numbers, as Louise mentioned, the numbers of visits have been down. We've shifted almost everything to telehealth. I think it's interesting when we talk about reopening, because primary care never closed. Most places, in fact, all of our sites stayed open physically and worked incredibly hard to see patients who needed to see us safely. I know some places did not have protective equipment. They were not able to stay physically open and continue to do work by telephone, by video visit. We've had a lot of people driving all over the city and all over the state to deliver people essential medications. I've done 2 visits on one of my patients' porches to look at her through the window and check on her and wave to her. I have been in the clinic physically. I drained an abscess, which you cannot do via telehealth. One of our teams delivered a baby in one of our rural clinics last week. We are seeing an incredible number of people coming in already and referring a higher number of people to emergency departments and hospitals than we normally would, just based on 2 months of deferred care. I think also, as Louise said, chronic physical and mental health conditions do not miraculously disappear, and many are worsening. People are finding themselves socially isolated. They're not able to get outdoors and exercise in the places where they normally go. They're not getting access to healthy foods. Infectious diseases do not go away. I think we've seen some articles about potential measles outbreaks and other things being predicted, which I think are real concerns. So there's a lot of creative work happening around how do we do preventive care as well as chronic disease care very creatively. And one of the other things I've been very worried about is talk about how telehealth is keeping everyone safe. And I think in some cases, you absolutely have to be seen in person to be safely evaluated. And so we're seeing, again, some people that are not coming in person and then having exacerbations of very serious conditions happen. One of my patients had a bowel obstruction and then a bowel perforation because we were working very diligently to try to get her to come in, and she was very fearful until things were far along the path. So she just got out of almost a 3-week hospitalization related to that complication. So absolutely seeing it now. Delivering babies in clinic, not normal. People with bowel perforations waiting at home several days, not normal. And that is just going to continue to skyrocket as the weeks move forward.
Yeah, I think there was one paper after one of the Superstorm Sandy that showed that the impact of deferred care lingered for 2 years after the event. And that was just a short, compared to this, a short, less than 1 week event that then had significant repercussions going forward. But let's talk sort of a little bit prospectively, because I know that particularly that both of you, but certainly you, Louise, have been working very hard to get your primary care providers, your FQHCs, and your health centers personal protective equipment, and to help them sort of do testing and so forth. So tell me about what you think, the nitty gritty of what you think it's really going to take to kind of fully reopen for business. What is it going to look like in the next 6 months? What do providers need? What are the chances of them getting it? What do patients need? So tell me about what how you're perceiving and supporting your members in terms of this reopening conversation.
Absolutely. And I think, so the big kind of cloud over our head is something that's just not known, is known whether or not there can be an immunity to this, vaccines, all of those sorts of things. Those big unknowns impact everything that we're doing on the ground. People are reopening. They're starting to reopen just a little bit at a time. Some of our members are saying, okay, well, our folks need vaccines. Let's do drive-up vaccine clinics and figure out how you can safely administer a vaccine to a kid in a car. And that way you're minimizing exposure. Thinking about just what's the PPE burn rate on coming back into clinic, and to making sure, and I'm talking just the medical side, the dental is a whole nother thing. It's just another category, but they need to know that their staff is safe and that they are protected from infection. They need to know that patients are safe and they're protected from infection, and that they can physically do this work in their physical plant in a way that's safe for everybody. And when you add that into the dental side of things, it just magnifies the safety issues, just magnifies them so much. So it's really this issue of safety and more universal testing, because so long as we don't have everybody tested, we don't actually know what the impact of this virus has been. And unfortunately, even though we know that there's been a higher instance for communities of color and low income communities, they've been under tested here in Los Angeles. So we don't actually know what the real impact of this has been. So more universal testing to know just what our prevalence rate is and our morbidity and mortality rate, to just the equipment to be able to make sure that our folks are safe, and additional testing so that we can test people. Are we going to have to test people before they come in for a visit? How often are we going to need to make sure our staff get tested? All of these sorts of things, in addition to that great big unknown in the sky, that's going to influence all of that.
And Jennifer, why don't you tell us a little bit about what you think about, you say on the one hand, primary care never closes. On the other hand, you have seen reduced visit volume, both because of the providers have asked people to stay at home if they didn't need to, I assume, but also because of patient fear. What are the concrete things that you're doing to support your provider network to reopen safely?
So we have been very fortunate to have a number of people working diligently here at Oregon Health and Science University, helping collaborate across primary care. And I think a number of places have been doing similar work. And as I said, we're fortunate. We have a large system. We have a number of different disciplines collaborating. So we have been doing a lot of work around cohorting patients. Again, we know that there are asymptomatic carriers, so we're not going to be able to keep 100% of infected individuals out, and are really working towards universal precautions with everyone wearing masks and doing the deep cleans and sanitizing and whatnot. We're also able to have respiratory clinics that are dedicated to sick patients, and really wanting patients to go to those clinics such that other clinics can, as much as possible, not have acutely infected individuals with fevers and coughs and potentially more infectious. We have developed an amazing hotline. One of the things that we saw coming out of Italy and other countries was that a place where infection was spreading rapidly, and one of the places where a lot of community members were getting infected, were healthcare settings. So we worked really diligently to set up a hotline where we could have patients call, get questions answered, a clinical assessment. If they had moderate or severe symptoms, they could have a virtual visit initially, and then could be routed to the respiratory clinic or the emergency department. And after about 10 days getting that stood up, and then a month worth of calls and data, we were able to successfully treat over 2,500 people by phone, and only 7 referred to the emergency department, which we found to be a real successful intervention. I think that a number of those people, if they hadn't been able to get through by phone, they would have ended up in a physical location and not needed to be there. So lots of things happening in that regard, creatively opening spaces in ways that everyone is, with, you know, putting chairs physically distance, remodeling waiting rooms overnight, remodeling workspaces overnight, measuring those workspaces out, cohorting people such that a team of people are working from home one week and a group of people are working in the clinic. So if there is an outbreak or a number of staff are exposed, you have another team that can then come in and continue to provide that essential care while the team that was exposed is under quarantine. So just lots and lots of ideas happening there, and real transformation overnight. I will share a number of resources. People can go to our website and download a guide that our Office of Primary Care and Population Health, in partnership with our students and residents and teams at OHSU, developed to share. I think one of the challenges right now is we know how essential primary care is, and we're all trying to do this work all at the same time. So it's been difficult to share those lessons learned because we're all doing this work simultaneously. Our hope was that we've done a lot of hard work and we want to share it as quickly as possible. The challenge now is trying to keep that information updated as new information comes out, minute by minute and hour by hour. So the more that we can across primary care share this information, I think the better off we'll be.
Jen, you bring up a really good point, because I think as we look across our 65 members, their patient populations are also very different depending on who they serve. From our folks who are really came up out of HIV care versus pediatrics versus seniors and programs for all-inclusive care for the elderly. So really thinking very differently about what the services are and how they're safely brought back online, and the population and how they move and how they live and what their risks are. So really trying to be thoughtful about that. And what I've noticed, and I appreciate just the grouping of what you guys have been doing on our office, on our side. We have peer networks, and that's been our jam for a long time, but it really has, and jam is a clinical term, but that really has been, you know, one of the things that has been a strength throughout all of this. Our CMOs are talking on the phone once a week. Our COOs, our CFOs, our health educators, you name it, all of our peer groups are getting together saying, how are you dealing with this? How are you dealing with that? How are you dealing? And then how do I translate to my population? I can't get my seniors to do telehealth. How do you deal with telehealth and persons experiencing homelessness? What do you know, all of these different questions, and trying to tease them out for the different populations, the different types of service settings. It's really important. And I think the important piece about telehealth and telephone is taking the lessons that we've learned from that and continuing to say that needs to continue to carry its weight in this new reality, so that the in-person primary care is really only the stuff that needs to be in person.
Yeah, I think one of the real benefits and real strengths of primary care is we do have collaboratives. We have a long history of having practice-based research networks that have shared lessons from each other. We do learning collaboratives really well. We have a number of extension services in different states. One of the early ECHO networks started to share lessons learned and answer questions about COVID-19 was started in Oregon by the Oregon Rural Practice-Based Research Network, and they did a phenomenal job. And a small state like Oregon had over 700 people on their weekly calls, and we're just sharing information. And what we recognized at the university was questions were coming in rapid fire in the chat room that it was not possible to answer. There were hundreds of questions coming in, and so we quickly organized medical students who had been sidelined during this time to answer those questions, to do a significant amount of work supported by an awesome group of faculty, get that information out there. And so I just think everybody's been jumping in primary care. As always, we're being nimble, we're being smart, we're talking to each other, we're listening to each other. It still is an incredible challenge because so much is happening in real time. One of the other things that I have really appreciated about our primary care teams is we have relationships with people. So it's not a protocol cookie cutter standard that's going to tell you who can come in and who needs to come in. Like, you can put all those graphs together, and that's great to say, these are the conditions that you can treat by telemedicine, and these are the conditions that you need to see people in person. And then there's the relationship in the real person. So I can look through my list of patients and say, yes, for these 90%, they need to be seen in person, but this person actually isn't going to come in, and we need to call them, and I need to go to their porch and see them through the window and make sure they're doing okay. So those relationships are so critical right now, and it's going to help us understand, as you said, the individual population and the individual patient, and how we can serve them and how we can best keep them healthy, keep them safe, and get care to them. Again, we've had pharmacists delivering medications across the city to people. I had an MA who, a patient had a fever. I thought she had a UTI. My MA drove over to her house to deliver a kit to her porch where she could collect her urine, and then someone else picked it up to take it to the lab. I mean, people are doing amazing things right now. And the challenge is, how do you fund all that? How do you sustain all that? Our communities need us more than ever. And as we know, we have a very broken funding system, and we have a lot of primary care teams already at risk of collapse, and some have gone away.
Yeah, so we're going to get to the financial stuff, I think, a little bit at the end, but I kind of want to go back to a couple of things. First of all, I just want to let people know that a lot of the resources, we're going to be sending them out that you've provided with us, Jen. And if you have any, Louise, that would be great. We'll send them out in an email to everyone who's registered for this webinar. And it would be great to know where people can get access to them. I think there are two things that people need, so it'd be interesting to hear more about this. You know, one of them is that there's a certain amount of, just like checklists. What are the 5, 10, whatever it is, things that I need to do to reopen my office successfully, whether you're a larger FQHC or a smaller health center. And so those kinds of things. Then I think there's that whole more in-depth conversation that primary care providers need to have with each other. A lot of that has been going on certainly among the hospitalists, the folks who are really working in hospitals, to say, oh, I saw this, what did you do? How are you managing this? What happened when you tried this medication or this issue? And that's how a lot of these things have come up around, proning or turning people over who are on ventilators, things that are not in a book somewhere really, but are, out of direct experience. And I think one of the things that I'm seeing certainly in New York, and I'm glad to know that it's happening in Oregon, is this need that people do have and want to talk to each other about what they're seeing cases, how they're managing specifically. And I think it's great to hear that you've got peer networks. If there's any other advice you have about how other states can set up those kinds of things, that would be really helpful. Because I think primary care providers have largely been left out of the conversation, at least here in New York City. And that I think is a big concern. And I think it's true for a number of other cities and states.
Well, that was one of our goals, I think, seeing the ECHO network and how many people were coming together weekly on that call and continue to come together. We then said, we'd like to have this hotline available for teams, for physicians and advanced practice providers and nurses and other people around the state, office managers, to call in and have conversations with us. We're happy to share resources, but we know it's bidirectional. They're learning lessons that we might not know and hearing things that we might not hear. And so how can we then use some of these spaces to help share that information? And it is a challenge because people's time is very precious and very limited. So we were trying to figure out creatively. So we do have this primary care consult line. In rural Oregon, our primary care docs call the university to get a cardiologist on the line, to get a trauma surgeon on the line, and get those consults. And it's a lifeline for them. Now we're really trying to do that from the primary care perspective as well, as how can we support people and how can we share resources? And then again, when we learn lessons, and that's the primary care extension program concept. I mean, that's the concept that's been out for several years about modernizing primary care, supporting primary care, providing this technical assistance, and doing it in real time as much as possible and when people need it. And so we're doing that. I know we're getting to the conversation later about financial situation and vulnerabilities there, but 2 months ago when we developed this hotline concept, I was really excited about being able to be on the other end of this phone line and provide technical assistance and provide all these resources. And now I'm realizing that no matter how many technical resources we have or how many practice coaches and facilitators we have, if the practice closes, we are not helping them and we're not going to be able to help them. Last week, Louise, you said, someone on your panel said, when someone's drowning, you need to throw them a life preserver, not teach them how to do the backstroke. And we're at that point right now. So I worry. I love all the technical assistance. That's what we're here for. I want to be helpful in that way. But I worry about the lifeline, and I worry about survival, and then providing the assistance that's needed.
And I want to weigh in on that. I think it's that piece of the checklist versus a learning mindset and agile organizations. I think there have been so many initiatives. Our members have been going through initiative overload. It's going to be health homes, and it's going to be this or that, and they've been trying to reorganize their practices over and over and over again to insert whatever initiative it is into it, as opposed. And so what we've been saying for a long time is, let's break this all apart. Let's think about, how do you develop agile, learning focused organizations that can adapt to environments, that have the integration within their teams, the communication structures. We are the disaster resource center for our members. So we do exercises. We've been doing it, it's been almost 20 years we've been working with them. We supply their PPE, we do them trainings on emergencies, but we've never trained for this type of emergency. We've done the Great Shakeout, gotten ready for earthquakes, active shooters, nonviolent crisis intervention, but every emergency that we've planned for has been an acute crisis with an aftermath. And the thing that's so different about what we're dealing with right now is there's nothing acute and sudden about COVID-19. It is a marathon of emergency. So thinking about, how do we just kind of and that learning mindset, because as we learn about the virus, we need to go back and think about, okay, well, maybe spread happens here. Oh, wait, maybe that patient population is at risk after a while. We do need to worry about kids as well as seniors and others. So I think those structures that we've put in place in advance are just, they're fundamental in the limited success that we've had. And it's really hard to build those structures when you're in crisis. Crisis is not a time when weak organizations get strong.
I think that's a really good point. I'd be interested, I hear you about initiative fatigue. I think it's absolutely true. And I think that what we've been trying to do is sort of say, here's a pathway for primary care, and that's like the kind of have people sort of go down that pathway to provide high quality care that's accessible and affordable. So I wonder what you think are the top key regulatory issues that you think the states or the federal government should either initiate or maintain in order to ensure primary care accessibility in this next period. What really matters from a changing the regulatory framework? I've been always interested in the fact that that all of a sudden we could make big changes in telehealth very quickly. It didn't require months and years of discussion. But I worry that whether the right things will be maintained or to support primary care, or whether the wrong things will be reimposed. Just some of your sense about the regulatory framework. Jen, do you want to start that one?
I think my bottom line is that transformation of primary care needs to be based on what patients, families, and communities need, not what payers dictate. Amen. I can go on and on about this, but telehealth is a Band-Aid. There's a gaping hole there, and the Band-Aid is, let's pay for more transactional care, and let's put in pages and pages of requirements about how to do telehealth and how to bill for it and how to keep seeing someone every 10 or 15 minutes, when what the patient really needs is you to drive over to their house and see them on the porch, or you to give them a phone call and help them adjust their meds. I mean, we really need the flexibility, we need the adaptability, and one size is not going to fit all communities, one size is not going to fit all populations. It needs to be recognized that primary care never closes. We are essential. We are here for communities. I think we're all beginning to see communities worried that their favorite restaurant is going to close, or their favorite gift shop is going to close, or all these really amazing places that we love to go. I don't think people even think that their doctor's office might close, or the primary care medical home that they've gone to for 10 years might close. They think it's going to be there just like the fire department is when and if there's a fire. They don't understand it's funded differently. And we have to get over this mindset of requiring primary care to fund itself in this very antiquated archaic fee-for-service way. We need to recognize it's a service that every single person in this country needs. It needs to be flexible. It needs to be supported and sustained in good times and bad, and strengthened.
Amen and hallelujah. I'm going to give amen. I think looking at like there's the regulatory side and first and kind of in order of, you know, sort of how first congressionally, we need more money, because if we don't get the investments that are needed to prop up our state, we are going to lose all of our advances that we had under the Affordable Care Act. And that's other states as well. So I think all of the regulatory dreams that we have are nothing if the federal government doesn't put out more cash to support states and their infrastructure. Our entire social service delivery system is on the chopping block if there's not more federal investment. So get that stabilized. And then because our dealing with primary care, unfortunately, we and all of our social service advocate friends are going to the Capitol and saying, what, cut us or cut them? We shouldn't have to choose, because food, housing, the health, you shouldn't have to choose between. We're a package deal. So, and I think that just kind of doing that, it's interesting when in a crisis, what you can accomplish, you know, suddenly turning on telehealth, which we've been begging for forever. It's like ready, set, innovate. Well, LA County suddenly figured out we could house all these people experiencing homelessness. How did that happen? How did we just suddenly get all these folks off the street and into places where they have a bed? And now it would be an incredible disservice for them to be unsheltered again after this crisis. So just all of the recognizing that housing and health are intertwined. And so when states put up waivers, healthcare waivers that include housing spending, they need to be approved. Because how are we going to deal with anybody's health if they're unhoused? And then, you know, payment reform, absolutely. Payment modernization, absolutely. We're pushing for this already, because this whole billable visit, the tyranny of the billable visit, the tyranny of the billable provider, it takes away, and look, I'm an FQHC advocate, so people that love PPS, you can email me all your hate mail later, but we need to get out of that so that we can recognize the team. And so if we're not, you know, really thinking differently about how we're paying for this and how it's structured, what can be done outside the four walls, and should be done outside the four walls, whether that's our street teams that are doing backpack medicine on Skid Row, or that's folks going to the Project Room Key sites for people experiencing homelessness, what have you. We've got to break this apart and think about how it can be done more smart. I will also say we're in a managed care environment, and managed care doesn't work for people experiencing homelessness. If you don't have a home, how can you have a medical home, right? That you are going to stay, if you're transient and you're getting moved from this shelter to that shelter that's staffed by different healthcare providers, the medical home concept needs to be re-envisioned for people experiencing homelessness in a way that you can have multiple care, providers that care for you, and they're recognized as being adjuncts to your medical home.
So for those people who may not have completely understood what Louise was saying earlier, the federally qualified health centers have a system of prospective payment system, which is a fee for service visit amount, in addition to some other funding that they get. The point being that you have to have a threshold visit in order to achieve that dollar amount. But I think that if we think, so let's just jump into this question. I mean, you know, people are talking now about, you know, primary care needs a Marshall Plan. You know, we need immediate funding, yes, for just kind of the basics, for PPE. You can't, as a primary care provider, you can't compete with a city or a state or another government or a hospital even, you know, for protective equipment for your staff. And most primary care providers before this, my best guess is they had gloves, they might have had a few masks on hand, but they didn't have a lot else. So this is a very big change in how primary care providers need to move forward, and we need that kind of funding up front. But I guess I want to ask you, what else do you think we need? I mean, in your dream payment system for primary care, you know, what is it that we could do, recognizing that we've made so many changes so far, we actually could go this extra mile. So not dream as in, oh, it'll never happen, it's not possible, but really, like, what do you think are the immediate things that we could do? We could put them into place this week if we wanted to make primary care work. And my question specifically is, do you think it's time to start talking about a global prospective payment? to really transform the construct of every individual insurer pays differently and every Medicaid program pays differently. And we really think about communities and what you could get globally, prospectively as a payment. Is this a moment where it's finally right for us to really talk about this?
Yes, I think some people have been talking about this a very long time. And I know that there's a lot of details and all those need to be worked out. But for me, I think about it simply. Oregon is one of the states that says that 12% of total healthcare spend should go to primary care. We need to work out the denominator so that we're including all healthcare spending in that, and thus we can then calculate the 12% accurately. And then we need to figure out what's the definition of primary care. What does that 12% go to? It goes first, off the top at the beginning of the year, to be proactive, to invest in that foundation, not like, oh, if there is money at the end of the year, we might give it to primary care. No, primary care goes first. We fund it globally. There are other countries like the Netherlands and a whole number of others who figure out who's in my population and make sure that everyone's registered with a PCP. So then the PCP knows who's in your population. I know that, as Louise mentioned, there's complications with mobile populations and people bouncing around between different communities and different PCPs, and how do you attribute those patients? But that's a small subset of our population, and I think we can find creative solutions to get them the care they need. I think overall, it's figuring out, where's your primary care medical home? How do we support that home holistically, globally? What services are covered? And then ultimately, how do we incentivize that group to provide high quality care? How do we hold them accountable for providing high quality care, and in some way that is safe, ethical, and gets around some of the concerns about managed care gatekeeping in the past? If that primary care practice and that primary care team or that network does an amazing job of keeping those people healthy, then they share in the savings that the entire system and the entire state benefits from the care they're providing. And I know that sounds simple. I know it's been difficult to do over the last several decades, but this is the time to do it, and we need to move forward.
Oregon has been a leader in this whole idea of putting forward, a definition, measuring, and then ensuring that a certain proportion has to go to primary care. And there's a number of other states that have done that too. We're very interested in moving New York State to be one of those, and I think in California there have been some efforts towards this, but it hasn't quite been developed yet. But Louise, what are your thoughts about, prospective global payment, really transforming the system? Is what they're doing sort of at CMS, the primary care first, those initiatives, is that sufficient, or does it not yet address everything that your community of primary care providers need?
So, and I just want to it's tough to dream about a future when you're in the middle of a nightmare. So it's a little, I know these conversations are starting to happen, but it's hard to get the right people engaged because of what they're dealing with in the world of crisis. What we've dealt with here, and I just want to see on the CMS side, and especially with some of the relief and other stuff that's come down, a lot of the methodology has been focused on Medicare, which means that we've lost, because Medicare is only 5% of coverage of our 1.7 million patients. The vast majority of them are either uninsured, meaning they're undocumented, or they're on our Medi-Cal, our Medicaid program. And what I'll say is that we're in a managed care market, and we're in a unique managed care market in that we do have a nonprofit managed care plan, LA Care Health Plan, one of the largest public health plans in the nation. I think they have like 3 million lives. And we have, consumers have seats on the board. Now, through one of the projects we did with them just a year and a half ago, our members outperformed the Mayo Clinic on diabetes indicators. So, you can get really innovative in a managed care environment if you do the right interventions, and the safety net can innovate. And part of that is about, one, putting in the resources so that you can't just transform and give a new payment and then folks say, wake up tomorrow and go, oh, I'm going to do care differently. It's about the additional technical assistance that needs to come in, that thinks about workflow, that thinks about the team design, the data design, information sharing, because all of this needs to be brought to bear. And what we've done so far in California, statewide, is we have a alternative payment methodology that we put forward. It passed in law. We went to CMS. They said, let's do it in a waiver. And we said, no, we're not going to touch waivers with this administration. Thank you very much. And so we're going back to it and trying to do it through a state plan amendment but it is a very primary care. It's not, there's nothing global about our payment reform. It's primary care, just trying to get out of the widgets that you count for the individual visits. So in LA County, for example, our members get a member per month of about $32 to see their uninsured patients from the county. And that's because they took their average visit rate with a discount, multiplied it by 3.2, and then divided by 12, and bam, there's a payment system. It's very rudimentary, but it's what we had, so we dealt with it. But even starting with baby steps and just saying, let's just get to a primary care payment model that gets out of fee for service, and then let's bring some more folks in and build it out, build it out, build it out. I will say the one challenge that we're going to have coming out of this on the performance measures is 2020 garbage is 2020 garbage. 2020 data is going to be garbage, period. Our health indicators that we're reporting up to the feds, up to the state, to our managed care plans, it's this year is, we would like to just take this year and put it aside and say, okay, now let's focus on what happens in subsequent years, just because of the lack of visits, and we're not going to be hitting a lot of our indicators.
Yeah, I mean, I think it's an interesting problem when you talk about quality metrics. When a lot of people haven't come in to be seen, there you won't be able to track some of those things. I also think that there's going to be some really interesting conversations around shared savings, to the extent that right now, if people aren't being seen and they're covered by managed care, then those savings accrue right now to the insurer. And so I think some of the discussion in this very specific period about what will happen with the data and what will happen with the shared savings programs for 2020 is actually something that I think will really be critically important to make sure that primary care providers have the funding to go forward in this next period to actually to remain. I mean, I know that the American Academy of Family Physicians has projected that it might be as many as 60% of small providers' office will go under in this period. And it seems to me that those are critically important providers as part of the ecosystem of providers, that we can't let them close. But I think that unless there's something done about not only immediate payments, but sort of this broader question of how do we maintain those primary care practices over time, is actually really, really a relevant question. And I think that it would be interesting to hear what you all have been doing in terms of talking to your insurers. So there's the state and the federal regulatory environment, but Jen, I think the managed care structure is a little different in Oregon. Have you been talking to your managed care providers about primary care and what they're thinking of in this next 6 months to a year in terms of payment?
Yeah, so we've been really fortunate here in Oregon to have long-term managed care organizations like Care Oregon, which launched into the Medicaid managed care market over 20 years ago. And they've been forward thinking, and they've really put together a global payment for primary care. A number of our coordinated care organizations have done the same, even prior to the pandemic. So as you mentioned, Louise, Oregon is a little further on that continuum. And so I think we're fortunate to have people doing this. I think the challenge still lies in even some of our small rural primary care practices have over 30 payers, and all those payers do things differently and make up different rules on a continual basis. And so this does, I think, really need to be done at the federal level or the state level, and it needs to be collectively done in a way that simplifies it and modernizes the payment and does it in a global way. And whether that's a global payment for only the primary care services or some way that it's done globally for the entire community is going to be key. Primary care is suffering. I think primary care is, the tip of the spear in the pandemic, is obviously the canary in the coal mine right now. But we also have huge hospital systems like Mayo, who people thought were too big to fail. They are failing, and the hospitals are running to the feds, begging for billions of dollars right now. So the fee-for-service payment plan for primary care is a disaster. It's also not a sustainable model for an entire healthcare system. And so I agree that it's difficult to solve some of these big structural problems amidst the pandemic and amidst the crisis. And this is the time to do it. Britain's National Health Service was created out of World War II when the world was crumbling. The Marshall Plan was then created to help Germany rebuild. I know we have now a Marshall Plan for primary care that's been developed. there's a lot that really does need to come out of this crisis. And unfortunately, we need to be doing that work simultaneously to keeping people safe and healthy and doing all the day-to-day work in the trenches on the ground.
And I think we are getting to that place where we can start to have that conversation. As I've been thinking about sort of our world, we were sitting smack dab in the world of relief and crisis up until most recently, where kind of the same way where our states are doing phased approaches to reopening. You're in phase 1, we're in phase 2, but it's kind of the same thing. We just number them differently. But is this whole piece of like getting from relief to recovery, and the recovery to the new reality. And so within recovery, as we're sort of saying, okay, now we've stopped the bleeding, let's see, like look up and see how we need to get to the new reality, but also what do we need to define that new reality as? What is that going to be? And we're lucky in California in that our Medicaid director used to run a local initiative nonprofit health plan. And he's a physician as well. So really lucky for us. But with that said, states don't innovate. I mean, you don't have a behemoth bureaucracy suddenly turning things around in a pinch. That's where the role of us, of the stakeholders, the innovators and others can come together and say, yes, kick it off, be willing to innovate, but then let us help you think about how to do it. And I want to say on the, you kind of pointed to this, Louise, with just all the indicators and like your comment, Jen, about the health center that has, X number of managed care plans that they're all working with, the streamlining and the right sizing. And California was already in the process of doing this, with even just saying encounter data needs to be submitted in the same way, regardless of payer. People need to stop having local codes. People need to stop doing all of these one-off, because as we need to reduce the administrative burden that happens at the primary care side, because all too often that is what forces them to close, it's the overhead. They're fine with practicing care, but the amount of administrative burden that they need to take on to manage all of those different product lines is the thing that's going to crush them.
So I have one more question for you for general discussion, and then I'm going to do a couple questions on sort of a lightning round, as we have about 15 minutes more in this conversation. So, news came out this week. Not surprisingly, we published something that showed that the comorbidities, the low-income communities of color essentially are having higher morbidity and mortality from COVID-19. And it's certainly true in New York City that those communities correspond with communities that have less access to primary care overall and higher rates overall of hypertension, diabetes, and so forth. I have to say it didn't surprise me. I assume it didn't surprise either of you. So I guess my big question here is, in those communities of color, low-income communities of color, where there's already insufficient primary care access, how do we take this moment to actually say, not only do we want to make sure that the existing primary care doesn't close, but we actually expand primary care in those communities, specifically the ones that have been so deeply affected by this particular crisis. It's just an obvious correlation. I wonder what you think about increasing primary care access in the next year or two.
Oh, wow. I'm just trying to think about how do we get back to what we had before. I mean, I've got from the survey of 35 of our members, and this is 2-week-old data, 35 members reported they'd furloughed 723 staff, including layoffs. We're at 1,000 staff members that have been put on hold. We've reduced, over 1,000 hours a week in access, and closed 53 sites across our membership, and that's at least. So we got to reopen what we got. We got to remember that access, again, for these communities is going to look different. Where I'm sitting right now, I'm a gentrifier in South Los Angeles, and I'm in a hotspot. Surrounded, but I'm surrounded by our member health centers because of the Affordable Care Act and because of all of the expansions that came out of that. So I feel like we've got a lot of the points, the sites, but it's about rebuilding them and reshaping them and thinking about what that new reality needs to look like to improve access. Because even though there's sites all around where I live, how many bus rides is that? And do I need to go through different, neighborhoods or territories to get there? Is that going to be a problem for someone to have to do that kind of travel? So I think that we need to not lose the advances that we made through the ACA, absolutely, and everything since. And then double down on redefining what access looks like for communities, because I'll say we love doctors. Jen, I know you're a doctor. You're great, but it's the health educators, it's the promotoras, it's the people who get out into the community, and also for our behavioral health side, it's people with lived experience. They need to be part of the system so that we can get more people having trust in that.
Jen, any thoughts that you have about sort of increasing primary care access at this moment?
Great question. We know access to primary care saves lives. We know it reduces inequities, and what we do on the ground is critical. So I agree with Louise. I think maintaining, and this is where the lifeline is going to be incredibly important. I think we could look across the country, and again, I think those practices that are most stable right now and sustaining are those that have a global payment, those that are doing population health, that are being flexible and continuing to provide care in new and different ways. All practices are continuing to provide care in new and different ways. Some are getting paid for it and some are not. So we need to equalize that playing field. And then we need to really think about equity and getting out resources to where they're needed most. I was thinking in terms of a safety net and the fact that, our country overly relies on a safety net. The safety net is there in case of emergency for a few people if they fall through. If everyone falls through at once and hits the safety net, it collapses. We're seeing that happening already. And so working at the micro level and getting primary care out to the communities and doing the work on the ground is important. And then all the way up to the policy level is going to be critically important in getting a lot of these policies changed. And I know we have people working in all those places right now, and it's critically important. So I don't have any great answers. I think there is a lot that can be done at the state level, and perhaps in a state like Oregon where the population's smaller and people do know each other, we can do some of that at the state level. California maybe more at the county level or more local level. And then nationally, Louise, with your organization supporting people and helping us connect and share ideas. Again, I've been very heartened by the work that's going state by state in increasing primary care spend and having that be a great policy lever. And then with the work being done at CMS, I think despite it being focused on Medicare, a lot of times what CMS does for Medicare and then Medicaid does set the blueprint for other payers. And so the more that we can push on those levers, the better.
And I just want to say additionally, no solution about us without us. I mean, primary care needs to be at the table, and the communities of color and the folks who are most impacted, they need to be at the table and brought to the discussion, because those external solutions that get impressed upon us don't really solve much.
Well, and I think your point about health is about much more than healthcare. And so many of these inequities are related to deep-seated problems within our society: poverty, racism, inequities that go back generations. And so the policy work has to happen to expand primary care, but it also has to happen to improve policies that promote health overall.
So great. So we're kind of getting to the end of this. I have a couple quick questions to pose to you. Right now, it seems like public health and primary care have kind of diverged past. Public health maybe taking on contact tracing. What do you think the role of primary care should be in contact tracing? Kind of in a fairly quick answer. Jen, why don't you start, and then I'll turn to Louise.
I think every community is going to be different. We have rural communities where a family doctor is the primary care leader as well as the public health leader, and so those solutions are going to be different than a large city where there's a whole team of contact tracers and then working in close partnership with primary care for testing and getting as much information as they can about positive individuals that test positive for COVID, or identifying where that individual's been. So primary care I see as a great bridge between the traditional medical care system and the public health care system, and we are well poised to do as much or as little of that is needed in each individual community.
I will say ditto in the interest of time.
Okay, great. I mean, I'm pretty worried about all those people who are testing negative but still have symptoms. Who's managing them? How do we deal with that? So I think that that's really, to me, the connection's got to get made.
Yeah, and that's
across
where
the
our
country. And I
hotline.
think so far it hasn't.
Yeah, and that's where
developed.
we're really trying to figure out how to bring our hotline into that space. In Oregon, we have a study that's going out to 100,000 random households that will be getting symptoms checked and testing done. And then the question becomes, if there's a clinical need, where do they go? Do they go to their local primary care? 25% of Oregonians don't currently have a primary care provider. So we're trying to sort of figure out, okay, can they call this hotline to get a nurse on the line who's well versed in these issues and help them get the proper clinical care that's needed. So it's definitely blurring those boundaries between clinical care, medical care, public health, and taking care of communities. And I think we all need to collaborate in that space.
And there's an opportunity in crisis, because if there's an opportunity to get someone a medical home that doesn't currently have one, to get them connected to primary care, let's take it.
Right. I think one of the things that I've heard, though, is that a lot of the contact tracing organizations are saying, well, we should just refer them to the, nearest hospital because that's who they're connected with. And I think there is a concern that unless primary care is in this conversation, a lot of those people will be connected to, and hospitals do a lot of outpatient care. Let me not, deny that. I mean, primary care, it is sort of probably, maybe somewhere in a third of providers, but it's not the only place. And a lot of people, what happens to the 75% who actually do have a primary care provider, making sure that those primary care providers are viable. Let me ask a quick second question, which is, so physical plant modifications, what do you think people are going to need and how are they going to pay for it in terms of changing their physical plant? We obviously, we are a lender, so we do a lot of lending to support physical plant renovation and acquisition and development of new sites. But right now, primary care, the way look and feel of primary care is going to have to change. Louise, why don't you start?
We've done a lot of work on this in partnership with Capital Link, actually, in helping our members reflow their organization so they can be, get the most, least time through and the cycle time, and get really improve, patient outcomes and provider satisfaction, and really thinking about flow. We're going to have to take that and turn it on its head, because we were trying to maximize how many people you can get through a physical plant in X amount of time and make it pleasurable and this and that. And so it's more than just making sure the babies and the seniors aren't in the same waiting room. Like, we're like, okay, they'll be happier if they're apart. No, this is about how many physical humans can be in a waiting room at any one given time. For our members, and I imagine in other places, waiting in your car is not an option because they don't have cars and there isn't a parking lot per se. So the physical plant, I will say for dental, it's going to be brutal. It is going to be brutal. And you're going to see the whole issue of productivity and the number of visits. If you're cutting in half or more the number of people that can be in your dental bays at a given time, that's going to be incredible. And especially in areas where real estate has been horrible to get, there's really high cost to think about what the physical modifications need to be.
Anything to add on that, Jennifer?
I think it's, again, just going to be very creative. Doors are going to need to be put into buildings that make easy entrance and exit. There's going to be one-way flows. We've got some clinics working on that right now, where you go in one way and you kind of, so that you're not having a lot of people congregating in one space or passing each other in hallways, or and I agree, the issue with not having cars, and so how much can we do to bring services to people as opposed to having them all come into one physical space. And we've talked about this, where we we want to have clinics without walls. Now's our time to innovate in that regard. We've got to get that hardware and software out for people that can do virtual visits and can access those. Again, they're not safe for everything, they're not appropriate for everything, and that's where we as primary care teams are going to know our patients and know what they need and when they need it and where they need it. And so the flexibility to buy vehicles for clinics to go out and deliver services, the flexibility to, again, remodel buildings quickly. Yes, you can put up plexiglass in places where it'll limit spread, but it's going to need to be much more creative than plexiglass and a couple of new laptops being sent out to people's homes.
So I think, just given the time, we're going to have to leave it there. This was a really interesting and engaging conversation. I tried to paraphrase a lot of the questions that came in, so I think we covered a fair amount, but there's a lot more to talk about. I feel like the really important thing that I take out of this is that we need primary care leadership at the table to be thinking about how primary care is going to be able to engage in the future, and that this whole question about how do we get a flexible form of payment that is upfront, and by global, I really mean like the full patient population across insurers, really is what primary care needs in order to actually play its role, that I think would potentially attenuate what I believe will be a second wave of the COVID infections coming up, because I think that's inevitable. And if we do the work now to try to make sure that the primary care system is as strong as it can possibly be in this period, I think that will help attenuate a second or third wave of the epidemic. So I do have to say, Jennifer DeVoe and Louise McCarthy, thank you so much for spending this hour with us. We will be back in touch, as we think you are key leaders in your areas, and we all think that we need to make sure that we have a strong primary care voice in our cities, states, and counties, as well as nationally, in order to get done what we've talked about here today. So thank you for the work that you've been doing and for the work that you will continue to do. I want to just make sure that we can let everybody know our next conversation is going to be on Thursday, May 28th. It will be with Melissa Abrams from the Commonwealth Fund and Dr. Gloria Wilder from the Centene Corporation to be talking about sort of the future of primary care. Again, I hope that you will all join us, and we will send out to everyone the resources that Dr. DeVoe provided, as well as anything that Louise McCarthy provides to us. And we hope that you all will keep in touch. Thank you very much. Take care.
Thank you all.
Thank you. It was a pleasure. Bye.